Welcome everyone to the third part of our first QA forum of 2021. My name is Dr. Michael Novick. I am the Director of Education and Associate Director of Quality Assurance for vRad. Today we'll be talking about satisfaction of search misses. Feel free to pause the video to review our accreditation statement and the learning objectives for this lecture. With the bookkeeping out of the way, let's dive right into our cases. Our first patient is a 27-year-old man with abdominal pain. These are axial images from a CT scan of the abdomen and pelvis, and I generally like to do a quick look before I entertain my search pattern, just to get a general idea of what's going on, decide whether or not I need to place a critical call while I'm reviewing the non-emergent findings. And I think the pertinent finding in this case probably stands out in the left upper quadrant. And here are the coronal images from the same scan. Once again, there is obvious badness in the left upper quadrant, which we can take a closer look at when we're doing our full search. It's very important if you decide to do a quick look before you start your search pattern that you stick to your search pattern once you begin, because that's how you miss findings when you decide to skip something in your search pattern. As I'm sure you all saw, this is not an eye test. There's a collection in the left upper quadrant. It's complex, and while there's a differential diagnosis for this finding, it turned out to be a hematoma. But if you get carried away, as I often do describing the very exciting findings that you've made, you might miss the important findings in the adjacent left kidney, which is hypoperfused. In all likelihood, you did not. However, if you did not engage your search pattern from top to bottom, you may have missed another important finding. This patient also happens to have right-sided hydronephrosis. Secondary to an obstructing right UVJ calculus. As it turns out, the findings in the left upper quadrant were subacute, and in fact, the patient's abdominal discomfort was caused by the right-sided obstructive uropathy. Our next patient is an 88-year-old woman, status post-trauma. These are axial images from a CT scan of the head, and if you do a quick look, as I do, you'll probably notice immediately the subarachnoid blood products at the left anterior vertex. There are also senescent changes which are expected. It's very important to always review the reformatted images, particularly on head CTs in trauma cases. I always take a look at the tentorium here for subdural blood products. In this case, once again, those subarachnoid blood products at the left vertex are visible. As we discussed, there are subarachnoid blood products at the left anterior vertex. If you were satisfied with that finding and rushed through your search pattern, you might have missed additional areas of acute hemorrhage. More posteriorly in the left parietal lobe, and a bit higher up at the right anterior vertex. If you made all these findings, you might be feeling fairly satisfied that you had found all the blood products, but you would be wrong in this case. There is mild right parietal scalp swelling. Always use your soft tissue windows to look for areas of soft tissue swelling which can alert you to more important underlying findings. In this case, there is a small amount of subjacent extraaxial blood. So this patient has a small subdural hematoma in addition to the scattered areas of subarachnoid hemorrhage. Moving on to our next case, we have a 65-year-old woman with acute ankle pain. This is the initial plain radiograph taken when the patient first presented. and a follow-up image taken several weeks later when the patient presented with persistent pain. At that follow-up visit, a CT scan of the ankle was obtained. These are the axial images from that scan. The patient has pronounced osteopenia, which makes identifying fractures a little bit more difficult, but I think at least one of the findings should be clearly evident to you even on a first look. These are the coronal images from the same study. Once again, I think the major findings should be fairly obvious to you, although the osteopenia does make it somewhat more difficult. So reviewing our findings, here again is the initial plane radiograph, and I think you can all appreciate the prominent lateral soft tissue swelling. Which persists on the follow-up plane radiographs taken at the second visit. And while the soft tissue swelling was more prominent laterally, the major finding is actually on the medial aspect of the ankle at the medial malleolus. There is a subtle non-displaced fracture of the medial malleolus in the sagittal oblique plane. The fracture is a bit more conspicuous on this coronal image, and I think perhaps you can hallucinate just a little bit of cortication there at the fracture site, suggesting subacuity. Of course, we're talking about satisfaction of search today, so there's a second finding. Here along the plantar surface of the posterior calcaneus, there is a very subtle non-displaced fracture. Perhaps it's a bit more conspicuous here on this sagittal image. But I would venture to say that 9 times out of 10, I would miss this fracture if I didn't go systematically through all the bones of the ankle looking for fractures. Next up is an 18-year-old man with shoulder pain. These are axial images from a CT scan of the shoulder with the bone windows on. Of course, we're looking for fractures. We're going to take special care examining the ribs for non-displaced rib fractures. And of course, you'll recall from our search pattern lecture that we'll put the lung windows on at some point to exclude a pneumothorax. Here are the coronal images from the same scan. Once again, we have our bone windows on to look for fractures. And finally, the sagittal series. If the field of view includes the spine, you'll always want to have a look at that as well. This is a coronal image from the axial series, which demonstrates a displaced fracture of the clavicular shaft with overriding of the fracture fragments. More inferiorly on this axial image, we can see a displaced fracture of the scapular body. If you don't take the time to carefully review all of the osseous structures, this is a very easy fracture to miss. There is frequently artifact in this region from patient motion, and certainly you already have a fracture more superiorly in the clavicle, so satisfaction of search is at play. If you were unlucky enough to miss this fracture on the axial series, it is much more conspicuous on the coronal and sagittal images. So just another reminder to always review those series if you have them and ask for them if you don't. Our final case is a 63-year-old woman with a history of hiatal hernia. These are axial images from a non-contrast CT scan of the abdomen and pelvis. Of course, we already know the patient has a history of hiatal hernia, so we're going to be careful to evaluate that section of the scan. But always remember to engage your search pattern and review every element of the study. And the coronal images from the same patient, once again, the findings in the left upper quadrant are rather impressive. We're going to spend a lot of time scrutinizing those findings, given the patient history, but we're also going to review the rest of the scan systematically. So let's take a moment to review our findings. This is an image from the axial series. We have our known hiatal hernia containing a large portion of the stomach. Of course, if we have prior images, we want to compare the two to assess for any interval change. The stomach is dilated and there is an abrupt transition point at the level of the gastric antrum where there is some associated architectural distortion. So this patient in fact has gastric outlet obstruction. However, the patient has another even more important finding in the sigmoid colon. There is irregular localized colonic wall thickening with associated luminal narrowing, which is the classic imaging appearance of colon cancer. I think it's easy to see how one could miss this finding after identifying and describing the gastric outlet obstruction, particularly given the patient's clinical history, but if you religiously employ your search pattern, you are much less likely to do so. I used this article for my search pattern lecture as well. I think there's a lot of useful information in there if you have the time to check it out. Otherwise, thanks for joining me, and I will see you all next time.